this is a topic which I first got, and I thought, what new and what do I have to say that all of you don't know? And this is a topic that was told that is this the jumbling of words or this is something beyond that? So I have to speak for the next 10 to 15 minutes on the first line chemotherapy in adenosquamous and squamous. So my point here is to look at the peculiarity of the adenosquamous, which few of us have theoretically know, but very few actually know what exactly to do and how to go around it. And in the last part of my 4 or 5 slides, I'll go to the classical things, how we stick to and would like to treat on chemotherapy. For starters, I would like to put up very clearly that I'll be restricting my talk to the chemotherapy part of it and probably adding on the immunotherapy on the first line, and I would not dwell beyond the first line. So if you look at it, this is how the lung cancer histology looks like. We heard a very nice talk by Dr. Roche, and we heard about the liquid biopsies. I go back probably 20 years back now. And this is where it has been all about a small cell, non-small cell, and we have been taught about to go beyond that to adenosquamous and large cells. And if you look at it, there is a percentage of around 0.4 to 4%, which is actually eluded in the literature. It's very variable. And if you look at the first adenosquamous carcinoma was documented, the classification came into in 1978. It came from the Japan Lung Cancer Society. And it was looking at the component of squamous cell and adenocarcinoma. And they told at least one of them should be, each of them should account for 20% of the tumor. Go ahead, 3 years after, then they told that a diagnosis could be established as soon as you look at any component, the percentage just went off. And then there was a thing in 1985 that looked at that it could be based on corresponding typical characteristic which you find, maybe a keratin for a squamous cell or a gland formation in the adeno. But you come back to the WHO 1999, and that really stands till now, is that you should have at least 10% of the tumor under the light microscope. And this word of light microscope is important, but if you look at the electron microscopy, then this percentage of adenosquamous can go up to as high as 40%. So it's under light microscope, and each of the components should be at least 10% a squamous adeno. The other one could be major, one could minor, but at least 10% of the tissues should be at least adeno and squamous. And if I look at it, this is how a differentiation looks like for the mutation things from adenocarcinoma. You look at the EGFR, there have been very contrasting data for that. You do find literatures which also tell that the mutations, at least the EGFR in adenocarcinoma and adenosquamous, match each other to 30 to 40%. But there are literature which tell that the mutations which you look at, EGFR especially, is much more common in adeno, then little lesser in adenosquamous and much lesser in the squamous, around 4% that we know. But this is the thing, the consensus is around 30 to 40% adenosquamous would have a mutation that's around EGFR. They would have a 5 to 6% of an ALK mutation. The KRAS is little higher to 10 to 11% in contrast to the adenocarcinomas. The glandular component also decides upon the extent of EGFR mutation. The more the amount of the adenocarcinoma component, the more likelihood of getting EGFR mutations or other mutations as we normally see in a adenocarcinoma typical. Look at the prognosis, and that the prognosis is more documented in the operative setting. And they looked at it at the operative setting, and they found that if you have adenosquamous, they probably do much worse than if you have a pure component. And that's where I stop. The green line is a classical adenosquamous. There are other varieties. I'll stick to that. The take-home message is the adenosquamous normally have a poorer prognosis. And look at how we do. If I get adenosquamous, it's important that we diagnose it and what to do. Should we be starting chemotherapy? No. The first step what we should be doing in adenosquamous is we should be looking at the mutation analysis, send for a mutational as you normally do for your adenocarcinomas or a typical selected squamous cell, but you have to do a mutation because it is documented that around 30 to 40% would have some form of mutations which might alter your treatments. And the responses, if you look at adenosquamous, that's this part of it, then the adeno and then the squamous, the responses really match the adenocarcinoma. The basic point which I want to make is the responses on the mutation, if you find, or normal responses to therapy in adenosquamous actually matches more of adenocarcinoma and lesser to the squamous cell carcinomas. Even the median PFS is matching the adenocarcinoma. This is one of the first trials that was published for the adenosquamous, the largest group that published the effect of gefitinib and erlotinib. Now we come down to how they do. Yes, we all of us know that the patients who have mutations do better, and that's the same thing that is happening. What happens to the PDL1 expression? The PDL1 expression, as per the literature which I could gather, is actually correlating and matching in contrast to the components on which you do the mutation. The adenocarcinoma of the adenosquamous match the adenocarcinoma normally what you see, and the squamous cell match the PDL1 expression what you see in a squamous cell. So this is the adenosquamous. The take-home message should be here that you do for mutations. If you have a mutation, work as you do for a when you get a driver mutation. Otherwise, you choose chemotherapy. What chemo to choose, that would not be a consensus. What I would probably do is I would do something that works in both squamous cell and adeno. You could go for a taxane-based chemotherapy. Excuse me, or you could probably go for a gem carbo, which probably doesn't work that good in adeno, but at least works. I would prevent myself from going from a pemetrexed based chemotherapy. So now looking at the other parts of non-small cell, it started, we know 1990s, a lot of articles. We had all these articles telling you that Paclitaxel carbo became the standard of care in a publication in 1990s, and that showed that it was equal to vinorelbine and cisplatin. But this became the treatment of choice because Paclitaxel carbo was well tolerated in contrast to vinorelbine and cisplatin, and the disease progression and everything matched. But the therapy completed, if you look at Paclitaxel carbo, was much better. It was much better tolerated. Toxicity was better. That's how Paclitaxel carbo became a standard of care, which till now has been. Which chemotherapy has been better? Then the trial came, and this is the ECOG, which told you that anything with the platinum, actually a Paclitaxel, a gem cis, or a dosage cis, or a Paclitaxel carbo do not matter. Everything actually matches, and the ECOG told you that every line graph matches each other. Then came this trial in 2008, and this really showed us the pathway that adeno and non-squamous and adeno should be treated differently. This is the JMDB trial, and all of us know this trial. The main intent of the trial was to show the non-inferiority. It did not. The pemetrexed platinum matched the gem platinum, but when it came to the histology, we saw that the non-squamous did better with the pemetrexed arm, and the squamous did better with the gem arm. Although it was statistically significant, but the absolute values may not be huge, but definitely the curve was separating for the histologies. And that's where in 2008, the whole thing started. The Paramount study, we know now that we need to do a maintenance if you're giving chemotherapy first line. Now coming to the last part of my 2 slides, if you look at it, what more? We were really plateauing off beyond the maintenance. In 2012, we got the maintenance study till the immunotherapy came in. And this has been a very diverse. I put up on this slide to look at on a concise what we do, because we have spoken so much about it. These 3 trials, the Keynote 024, Keynote 042, and the Checkmate 026, looked at non-small cell lung cancer. They took both of it. If you look at this, the squamous cell alone was taken up only in 1 trial, that is Keynote 407. And the non-squamous was taken in for the Keynote 019, which is the most famous trial we always quote. The IMPOWER 150 and the IMPOWER 130, they looked at only non-squamous. That ISO has probably data more for the non-squamous. And what the data is, if you look at the non-small cell where they looked at only the PDL values, not at the histology, we found that we all know these trials to tell you that addition or alone immunotherapy beyond a particular PDL values of 50 has made a significant difference. All of us have been doing that. What strikes me in this is that the squamous cell, if you look at Keynote 047, the median OS was much inferior if I look at in statistical terms, in contrast to the non-squamous. The non-squamous in the PDL1, and if chemo is used with immuno, the absolute numbers of the survival actually looks much better. But all said and done, the only trial which we have in the first line for squamous, Keynote 407, did show an advantage of 15.9 versus 11.3 to combine the immunotherapy with Paclitaxel carbo arm. So to conclude, adenosquamous is an uncommon histopathological diagnosis. It is around in 0.4 to 4% of the literature that has been there, usually associated with a poorer prognosis, should undergo mutation analysis. That's my major take-home message. Otherwise, chemotherapy is the mainstay. I would stop myself from using pemetrexed based chemotherapy, probably go for a gem or a paclitaxel. That's one more important thing is when the adenocarcinoma squamous is there, they metastasize, and the metastasis could be of pure histological variety, single type. Means you could get a metastasis of pure squamous or adenocarcinoma. That you have to remember. The metastasis may not be necessarily a mixed histo. In non-small cell with driver mutation for the, I mean, total, it is targeted therapy. Sorry. Otherwise, this is what it is. From you do a molecular testing. If you have an oncogenic driver, you do it. All of us know that. If you don't have, we today in affordable class, we look at PDL values, we look at single agent pembrolizumab, or we look at chemotherapy plus immune checkpoint inhibitors. For majority of Indians, still this is out of the reach, and still chemotherapy followed by chemotherapy and some form of chemotherapy is the way we go ahead. And that's what my final take will be. And thank you, organizers. Thank you, Nitesh, for giving me the opportunity.